Welcome everybody to today's webinar sponsored by Transforming Chaplaincy, our friends at the Chaplaincy Innovation Lab and the Outpatient Care Research Network. We're delighted you could be with us. We had well over 500 registrants, which breaks a ton of records for us, so we couldn't be more happy. The title of today's webinar is Spiritual Care for Patients with Cancer. What can we learn from big data? And I'm going to turn this over to Transforming Chaplaincy's Executive Director, Dr. George Fichette.
Hey, Andy, thanks so much. Friends, let me add to Andy's welcome. We're so glad you can all be with us and really delighted to be able to share this webinar with you. Want to acknowledge this is a hard time for people working in healthcare, that the hospitals are just filled with a lot of very sick patients with COVID, and healthcare colleagues have been taking care of those patients for months and are getting tired. And we're thinking about you, hoping you can hang in there a few months. Really glad that we're beginning to see the vaccine, and we hope that in the coming weeks and coming months we'll be getting past the worst of this pandemic and be able to kind of continue to do the good work that we do. So thinking about you, we know this is not an easy time for people working in healthcare. Let me actually introduce today's moderator. Petra Sprick is a staff chaplain at the Levine Cancer Institute in Charlotte, North Carolina. Petra has a Master of Divinity from Princeton and a Master's in Public Health from the University of South Carolina. She was a Transforming Chaplaincy Fellow, and among other things, she has an interest in research about telechaplaincy. And Petra is the convener of Transforming Chaplaincy's network that focuses on oncology and outpatient spiritual care. And Petra, I'm going to turn it over to you, and appreciate you being here.
So glad to moderate this conversation today, and it is my great honor to introduce our panel and our presenter. Andy, I'll have you go to the next slide. So the first person I am introducing today is Dr. Elizabeth Palmer Kelley. She's the PI of the study that we will be talking about. She graduated from Elon University with a BA in Psychology and Women's and Gender Studies. She has a master's degree in Marriage and Family Therapy from Thomas Jefferson University and a PhD of Human Development and Family Science from The Ohio State. In 2017, she began her current role at Wexner Medical Center as a research analytics specialist. She collaborates on multiple projects with Dr. Pollock, one of our other presenters today, and they work on studies surrounding patient cancer care experience. She utilizes her expertise in mixed methods research and extensive training in human interactions to develop novel research projects focused on the importance of interpersonal relationships and their influence on the care experience and outcomes in cancer. With Dr. Pollock, most often she focuses on relationships, patient relationships with their physician, and the role of both patient and provider religious and spiritual beliefs during the cancer treatment. And Dr. Palmer Kelley, we're glad that you're here today.
Thanks, happy to be here.
Our presenters is Dr. Tim Pollock. Dr. Pollock received his undergraduate degree from Georgetown University, his medical degree from Tufts University School of Medicine. He completed his surgical training at the University of Michigan Hospital and spent 2 years at Massachusetts General Hospital as a surgical oncology research fellow. He completed his advanced surgical training in surgical oncology at the University of Texas MD Anderson Cancer Center, and completed a fellowship in medical ethics at the Harvard School of Public Health and a Master's of Theology at Harvard Divinity School. And if that wasn't enough impressive degrees, he's also received his PhD from the Johns Hopkins Bloomberg School of Public Health and Clinical Investigations. He is currently the chair of surgery at The Ohio State University Wexner Medical Center, where he holds the Urban Meyer III and Shelley Meyer Chair for Cancer Research. Dr. Pollack, we're also glad that you are here with us today. And then finally, in our OSU panel, we have the Reverend Hancy Newberry, who is the Director of the Department of Chaplaincy and Clinical Pastoral Education at Wexner Medical Center. She is a board-certified chaplain, an ordained Episcopal priest, a certified CPE educator. She got her BA in religion from the College of William and Mary and her MDiv from Harvard Divinity School. Hancy, we are glad that you are here today. And then finally, we have Kelsey White with us, who will be presenting on our article today. She got her BA in religion from Transylvania University, her MDiv from Union Seminary, and her Master of Science from the University of Louisville. She is a current PhD candidate in the Department of Health Management and Systems Research, and a research assistant, at the University of Louisville. This is a lot of credentials to get through, guys. We have a very impressive panel today. She was a Transforming Chaplaincy Research Fellow, and so we are thankful that she will be walking us through the article. We'll go ahead to the next slide, and I'll tell you a little bit about our agenda for today. First, Kelsey will summarize the study that we will be talking about. Then we're going to talk with our OSU panel, and each of our presenters will have a chance to answer a few questions that we have for them to better explore their study. We will then open the conversation up to our participants, where we'll do a Q&A, and you can type in questions that you want to ask our panel, and George Fitchett will moderate the questions that are coming in. We'll then do a quick wrap up. And I just want to once again say we're so glad that you could join us here today. And Kelsey, I'll turn it over to you.
Thanks, Petra. Go ahead and go to the next slide, Andy. So the complete citation for the article, I'm going to kind of walk you all through it on the screen in case you want to jump in and find it later. For those of you all who haven't spent some time with the study yet, I would encourage you to do so. It's one of the first to intentionally look at who utilizes pastoral care. So throughout our time together, I'm going to interchangeably use pastoral care, PC, chaplaincy care to refer to what they talk about as pastoral care in their article. And for those of you all who are not familiar, what the study aimed to do in general is to get at and to estimate the prevalence of pastoral care utilization among cancer patients. And they focus specifically on the Comprehensive Cancer Center at Ohio State. They also wanted to look specifically at the utilization of pastoral care in terms of patients' demographic characteristics, clinical characteristics, and then more specifically at what kind of chaplaincy services the patients used. Next slide. So how did they do this? Well, the team pulled EMR data from the electronic medical record retrospectively on any persons that have had a cancer diagnosis and who also had at least one inpatient or outpatient clinical encounter between January 2015 and August 2019. So they pulled all of this data from the EMR. They extracted information about individuals' age, race, marital status, whether or not the individuals spoke English as their primary language, and each person's religious affiliation. They also extracted variables around whether or not the individual had a documented do not resuscitate or DNR order, their cancer type and stage, as well as the length of their survivorship when they had been diagnosed. For their multivariate analysis, they examined what of those variables was actually associated with having at least one inpatient or outpatient chaplaincy visit. Next slide. So at the largest level, what they saw is they had 14,322 patients in this data set. Of that 14,000, around 36% actually utilized a chaplain. And among that 36%, 63% were inpatient when visited or utilizing pastoral care. 66% of the pastoral care encounters occurred due to a referral, and 48% of the referrals came from nurses. And then from diagnosis to first visit with a chaplain with pastoral care, their data reports that the median time was around 15 weeks. So these numbers alone are impressive because we've not really seen this in the published literature to date. Next slide. So on this table here that I've simplified just a little bit from what you may see in their article, we have the reported demographic characteristics for the entire sample, which is the first column, those who utilize chaplaincy care, the second column, and those who didn't in the third column. You'll see in the very last column the results of their bivariate analysis. And to remind you, when a p-value is less than 0.05, that indicates a statistically, go back, Andy, a statistically significant difference between the two groups for that specific variable. What we do is when you look at that table overall, what we see is that there's a difference between the two groups in terms of gender composition, race, marital status, religious identity, and then documented DNR order. So overall, the sample was around 62 years old, okay? And that was the same across both the total sample as well as those who received a chaplaincy visit and those who didn't. And then if you look at the gender composition, about 49% were female in among those who received a pastoral care visit, and about 62% were female among those who didn't utilize pastoral care. A majority of both groups were white, but a higher proportion of African Americans, around 12%, actually had a pastoral care visit rather than those who didn't. And then I'm going to skip down and draw your attention to the religious identity and the composition of the sample among the total sample and among those two groups. A large proportion of those who used pastoral care identified as Christian first, and then agnostic and unknown. When you look at the group not utilizing chaplaincy, there are fewer individuals identifying as Christian and a greater proportion of agnostic or unknown individuals. Both groups seem similar to the total sample in terms of the proportion of individuals who affiliate with either an Eastern religion or Judaism. And then finally, about 36% of those receiving pastoral care had a documented DNR order on their file, while only 8% of those who did not receive the pastoral care had such an order documented. Next slide. So in terms of the clinical characteristics of the sample, I took a lot of their data that they had presented in table 2 and put it here in terms of more of a visual representation. I took the top 5 most prevalent cancers within their whole sample. You can see those again on table 2, and created this graph. So the first set of bars is for the whole sample. The second one, those who utilized pastoral care, and then finally those who didn't. Breast cancer was the most frequent cancer diagnosis among the sample, as well as the most frequently occurring among those who did not receive pastoral care. When you look at the group that received pastoral care and utilized pastoral care, the proportion of folks with lung, liver, or pancreas, or multiple tumors actually had higher rates than among those who didn't. And then the proportion of folks with prostate or bladder cancer was actually higher among those who didn't utilize pastoral care. Next slide. For the DNR order, I think, again, visually, it kind of helps us to think about what's going on here. 82% of those in their sample did not have a documented DNR order. But then 18% who, among the 18% who did have one on file, 13% utilized chaplaincy care, while only 5% didn't. Next slide. All right, so this was my favorite. I took information from table 2 about cancer stage according to group, meaning pastoral care or no pastoral care, and created this graphic representation. So the gray bar represents those who received pastoral care, and then it corresponds with the cancer stage you see on the x-axis. And then the red bar being those who didn't receive pastoral care corresponding with the stage. As the cancer stage increases and you move from left to right on the x-axis, you can see the proportion of individuals who receive pastoral care actually increases. And then the proportion of folks not receiving pastoral care actually decreases. So as the acuity potentially increases of an individual's clinical needs, those folks who are higher, look like a higher proportion of those folks actually received and utilized chaplaincy care. Next slide. So for the next two slides, I've taken figures from the OSU team's article. This one shows you when the initial visit occurred for an individual based off their time since diagnosis. Most of the visits occurred about 52 weeks or more after initial diagnosis. And then the second largest proportion actually occurs right at diagnosis, it seems, and then exponentially decreases. Next slide. This one was my favorite that they put in the article. It talks about the pastoral care interventions. So what they did is they created this figure to show the proportion of patients that received each of the interventions noted in the EMR. And those interventions you can see listed on the left side of the screen. And then each shape in the figure corresponds to a different cancer type, right? So at the top, we see that over 50% had interventions related to the verbalization of feelings, sharing hopes and fears, identifying a support system, or sharing their life story. Interestingly, down near the bottom, between 0 and 10% of the patients who utilized pastoral care, did the patients experience a chaplain that either arranged or attended a family meeting or conference, guided someone for ethical discernment or decision making, or identified sources of spiritual struggle. The proportions range for cancer types when you get closer to the top. So you see how the shapes kind of are spread out horizontally, right? So those cancer types that, in terms of those interventions, right, there's a wider range. But then when you get to the bottom of these interventions, there really is a very narrow range of how often those types of interventions occurred, no matter or regardless the cancer type. Very, very interesting to me. Next slide. So finally, this table 3 is actually adapted from the team's table 3. Just simplified it for the sake of our conversation and for presentation here. I left off the confidence intervals just so that you all can have an easier time reading it on screen. So within this table, what they've reported are the odds ratios. An odds ratio is the odds or chance of somebody receiving a pastoral care visit based on a specific variable. Now, anything with an asterisk, again, reports a statistically significant result. So let me walk you through this in case you may not remember all the details you've learned about odds ratios. So with an odds ratio, anything greater than 1 means somebody's at an increased likelihood of having something done with regards to another group. And less than 1 means they're at a decreased likelihood. For example, you see that first odds ratio is 1.19 for females, meaning a female is at 19% higher odds than males. So females at 19% higher odds than males to have utilized pastoral care while controlling for all of the other variables in the model, such as age. It's important always to keep in mind the referent group when you interpret odds ratios. If you move to the second part of the table where we have religious identity, they've used agnostic as the referent group, so that those identifying as Christian are at 66% higher odds than agnostics to utilize pastoral care. And then you could look at those noted as unknown or other at around 29% lower odds than agnostic, or they have 29% lower odds than agnostic to utilize pastoral care. See, that odds ratio is below 1. Then you can look at the cancer type to see the variation among different diagnoses. And those are all in reference to somebody with breast cancer, so that individuals with multiple solid tumors, for example, are 4.51 times more likely to utilize pastoral care than those with breast cancer. Those with brain cancer, for example, 3.83 times more likely than those with breast cancer. So they reported the odds ratios for the stages of the cancers as well. They used stage 1 as their reference group. So obviously, and we saw this in a lot of the figures, the odds are higher among those with higher stage cancers as compared to stage 1. Individuals with an in situ diagnosis or a non-invasive precancerous type diagnosis were around 32% less likely than individuals with stage 1 to utilize chaplaincy care. And then finally, those with an existing DNR order were also at a 4.18 times more likely to utilize pastoral care than those without one. Now, not only are these important results for us to consider chaplaincy research, both utilization and access to it, they provide a strong example of the research that we could all compile with data that many of our departments may already have. So with that, I'm going to turn it back over to Petra.
Thank you, Kelsey. Andy, if you'll progress to the next slide. So we'll get each of our panelists a chance to answer a few questions that we have about these studies, and then we'll open up the questions to others. So Reverend Newberry, we'd like to start with you and to know a little bit more about the program that you are running, and specifically if you could tell us about your staffing, your referral process, and your priorities.
Okay, very good. Hello, everybody. I'm very happy to be here with you today. So I'd like to tell you a little story first about our cancer hospital's pastoral care staffing, because I think it is kind of significant in understanding the volume of our charting and the amount of chaplains we have. So in late 2015, the James Cancer Hospital had been in its brand new, beautiful tower building for about 8 months. And I had met and still do meet periodically with the sort of chief clinical officer of the James Cancer Hospital, who oversees ancillary services as well as other clinical services. And in that meeting, he asked me if I would develop a strategic plan for the optimal staffing of pastoral services, pastoral care services. Being in that new building, it was very clear that there was more support services that were needed. So our team set to work very busily to do all the research, all the documentation, the justification that we needed to do to come up with our plan. Our plan of staffing was approved, and at that point, I got busy as the director to hire literally 10 full-time chaplains in 2 years. So our current staffing for our James Cancer Hospital, and including ambulatory sites, is 11 full-time chaplains. So that tells you something about not only the value of spiritual care and pastoral support in the James Cancer leadership, but let's just say they put their money where their values were, and we're able to do that. So we, of that 11 chaplains dedicated to cancer services, 4 of them are inpatient, full-time inpatient chaplains. 4 of them are what I might call single shift, different kinds of shifts: night chaplain, swing shift, evening chaplain, and weekend, day and night weekend chaplains. And then we have 2, and some of those chaplains do some ambulatory work, and then 2 are dedicated ambulatory chaplains. So that staffing really does give us a wonderful opportunity to meet the vision of our strategic plan, which was to have embedded, comprehensive pastoral care services. That was the vision of our chief clinical officer, and that was my vision, that we have chaplains that are so well known within their units that they're assigned to, that they know the chaplain, they know the patients, and they know the staff very well. That all contributes then to the ability of our staff to receive a lot of referrals. So our staff is expected to certainly do their own rounding and make self-initiated visits, but the more embedded and known they are in their units and their clinical areas, the more connections and relationships they have with the staff, the providers, and the more referrals that they get. Our priorities of care, and that's not just in the cancer areas, but in general, would be, we expect our chaplains to focus their time on end of life as a highest priority. So responding to deaths or anything around the end of life, including DNR orders or DNRCC orders. Anything that is considered critical, that could be medically critical, or it could be pastorally or spiritually critical. Referrals, of course, and that could be a referral that comes from a patient, him or herself. It could be from the family member of a patient. As the data showed, we get a lot of referrals for nurses because we work so closely with nurses, but also healthcare providers, physicians, and APP providers. And we get consults through the computer as well as verbal calls, pages, all methods. And then we work very closely with the palliative care team in the James. And so we get, again, referrals from those folks. And we do expect our chaplains to see any palliative care patient within 48 hours of admission. So that's a little bit about our background, our priorities, and how our team provides pastoral services.
And it certainly seems from this data set that your team is accomplishing what they're trying to do, of really being able to talk to those advanced cancer patients at the times where they need it.
Yes, I would say that those results show me that reflects our priorities, because those cancer groups and even the stages, that was a very interesting slide around the cancer staging. That would reflect to me that we're there, you know, supporting people who are critically ill or at a very difficult place in their disease progression.
Yeah, thank you. Our second question, one of the things that this study reported is what was offered by the chaplain, and we see which interventions were offered most often and which interventions weren't offered that much. Can you tell us a little bit about your chaplain documentation and what you selected as choices of what they could indicate as their interventions?
Just to, again, a little background. Several years ago, I'm afraid I don't remember the date now, but at least 6 or 7 years ago, probably, Wexner Medical Center moved to Epic for the electronic medical record. And at that time, we took a sort of out of the box version of spiritual care charting. However, we found after a couple of years, 2 or 3 years, that didn't serve us too well. So we worked out with our own internal documentation charting IT staff the proposal that we design our own flow sheet, our spiritual care assessment flow sheet. So that's what we have now, is one that we designed. And so the interventions that we developed were, you know, different categories, I would say. So for example, we can provide categories like active listening, supportive presence. So you've seen some of those kinds of interventions that were documented. And I think, you know, there are others. There are things like sacraments, baptisms, anointing of the sick, communion, etc. So, you know, there are other choices, but I think a lot of what you see here are those things that any of you, I'm sure, who do work in the cancer field might resonate with as reflecting the pastoral spiritual needs of cancer patients. Verbalizing feelings about what's happening to them, sharing their hopes and their fears about how their disease progression is going to go. Looking for support, identifying, just telling their story, being able to have a listening ear to tell their story is very, very important. So I think the things that you see here probably are very reflective of the level of depth, I would say, conversations that our chaplains have about very critical issues of the meaning of life, the future, what the future may hold, fears and hopes, all of those things that are, I think, very much a part of a cancer patient's journey.
Thank you. And then our final question, when results of studies come in, it always feels a little bit like unwrapping a present, and the surprise of it and the excitement of it. And so our final question is, what about this study surprised you? And did any of the findings lead to any changes in the spiritual care that your team provides?
I would say, I'll just be honest to say, I don't think we've made any changes to date just because of the study and the article, but there's certainly a lot to chew on here, I would say for sure. You know, I guess I would just say I think there are things for us to explore, and that would be, I think, the fun of it is to sort of say, well, why this, and what do we think about that, particularly from the practitioners who are our chaplains who are actually making the visits, because I think they would have a lot of it and will have a lot of insight about how they understand that data. So there may be changes to come. We'll just put it that way. But for right now, yeah, we're still chewing on it.
It is a lot to chew on. Thank you. Well, we'll go to our next panelist and have a few questions for you, Dr. Palmer Kelley. So our first question is, what do you hope chaplains do with the findings from this study?
Well, I think just sort of that builds off where Hansi kind of left off is looking at the differences, first of all, between the patients that did or did not receive pastoral care. And I think what's really interesting that Hansi highlighted was that reflective of their actual practice policies from like an internal perspective, but also just examining if that met your expectations for your own patient population that you see in your own practice, or is there something that kind of stands out to you as far as interventions provided that lines up well or doesn't line up with your experience with your patients? So I think even though this study wasn't done at for almost everybody, I would assume their institution, there's still a lot that could be extrapolated and compared just to your own personal practice, your day-to-day clinical work, and to just sort of examine what some of those differences or similarities are. I think that kind of reflects the overall purpose of this article was really exploratory. So I think a lot of that exploration and comparison of the personal practice and the results that we found would be really enlightening for a lot of people.
It really was, working in a cancer center and seeing the quality of this data coming out. So thank you. Another thing that we're curious about is, you know, one of the unique parts of this study is you talked about when patients had their first encounter, when they utilized that chaplain. And you talk about how 1 in 3 patients utilized pastoral care, and that for most, they did so within the first 4 months of diagnosis, but we do see, you know, some of them are significantly later. Often in healthcare, we really want people to be sent to the specialist for their specific needs. So looking at this data, what do you make of it? What do you make of the timeline of that referral?
Yeah, that was definitely an interesting finding. And so I'm not a clinician, so it's possible that Hansi or Dr. Pollock could talk to, or providers, so they could speak to maybe their experience with like the flow of care and how that may have influenced that timeline. But in my mind, thinking from the perspective of what the data was, the data points that we collected, I think it's possible that we wanted to take the first data point that we got would be the first encounter of that patient with the OSU system. So it is possible that that folks didn't see pastoral care until they had an inpatient treatment that was, and so in that time between their first encounter at the OSU system and the point where they got pastoral care, there was treatment decision-making conversations, there was, you know, waiting to be scheduled, there's, you know, a whole host of things that could have been in between the time of the initial encounter again and that first visit from pastoral care. but I don't know if Hancy or Dr. Pollack want to maybe even speak to like the flow of care and how that may influence those results.
Yeah, I could just say, and this is of course, speculation, but one thing that comes to my mind is that a lot of the initial experience of cancer care happens in the ambulatory setting. And so, we have 2 dedicated ambulatory chaplains, but you could imagine how many people come and go through the ambulatory setting just every day. And then we have some other ambulatory clinics as well at the main campus here, but I'm just saying that there's a ton more ambulatory patients than we could ever see. So there is a relatively smaller number of ambulatory patients, which again might be where a lot of people start. And if you think about people that we saw, that increasing pastoral care services as people in a sense get more ill or their disease progresses, my guess is you're going to see more of those people in the hospital. So
that makes a lot of sense, that it just takes a while for us to know the acuity and get connected to them. Thank you for that exploration. Dr. Palmer-Kelley, just one more question at this point. So one of the very unique points about this study is the size of your sample, 14,000. It is an amazing number. And so it's really exciting for spiritual care and chaplain researchers to start to dream about what can be done with big data and what we can study. So what other important questions involving spiritual care do you think we can explore with big data?
Sure. So what I think could be one of the more important points moving forward is when we have these larger sample sizes, that usually allows us to compare subgroups a little bit more frequently. And so when we're comparing subgroups, we're again trying to detect differences or similarities in maybe the different demographic composition of the groups, or in this particular case, different needs. And so some of the stuff that we've actually started doing with this data now is drilling down and looking at specific diagnoses and comparing them. So we have a paper that's under review right now that we looked at people with more like serious or poor prognostic cancers, like HP cancers, and compared them against cancers that generally have a better prognosis, which was breast and prostate. And we saw that there were pretty significant differences between folks, the different diagnoses and what they needed from pastoral care. We also were able to kind of drill down even further and then look at folks within those cancer cohorts that had passed away at some point during our data collection period, and look and see then if again, there's different needs and just different things that we can attend to, that some of this data is, because it's pulled directly from clinical care, the results are kind of more easily, I think, translated back into the practice space. So again, I think getting a much more like nuanced understanding of patient needs based on a lot of different patient characteristics, disease, individual level, belief systems, so that we can further tailor our approach to more specific groups and their specific needs.
Thank you. We'll certainly look for that study being published as well. Andy, if you'll progress to the next slide. Dr. Pollack, we have a few questions for you at this time. So it's not often that we see a surgeon and someone so accredited getting involved in spiritual care research. Can you tell us a little bit about what motivated you to get involved in this research?
Yeah, sure. Well, first of all, Petra, I want to thank you, George, and Transforming Chaplaincy for taking an interest in our work and for inviting us to this webinar today. I've had a longstanding interest in kind of theology and spirituality. I'm a fairly religious person myself, and I actually majored in theology as an undergraduate and have had a longstanding interest in religion and spirituality predating my interest in medicine, actually. And then as I became more interested in medicine, I found that religion and spirituality was perhaps even more important, as I came across many patients who were dealing with real existential issues with regards to diagnosis, prognosis, family, issues, trying to find context and meaning within their healthcare and disease journey. So as a surgeon, I feel like that I kind of honed some technical skills, yet all of that still functions within a larger framework of, of who we are and how we view the world and how we make sense and meaning of all of this. And so, this is something that I've been doing for a while. And more recently, with the addition of Dr. Palmer to the group and working with, Hancy and the chaplaincy group here, I think we've just found a real synergism to work together to leverage, Liz's expertise in mixed methods and qualitative research. And then really our chaplaincy group is amazing here. I don't think there's many places. I was actually shocked to find the database that our chaplaincy group had kept such great records that allowed such a study to be performed. And that really allowed the research to happen, because frequently I know I have many research ideas, but it's just not feasible to do. We were very fortunate here at Ohio State to have such a stellar chaplaincy group that kept such great records that it was actually feasible to do a study like this. And I think it was important to do a study like this because kind of in wearing my administrative hat, as a chair, we want to know what utilization is, because if we're going to provide resources for something like chaplaincy, it's important to show leadership how important it is to patients in the medical center, how patients are actually utilizing it, what services are they utilizing, where are the gaps, where are the opportunities, where do we need to invest more resources. And one thing that spoke to me about this study is I think it was really interesting and important that chaplaincy was very present for patients in later stages of their disease. Yet I think that all of us would agree that, this is something that's important to patients across all stages of disease. And having an opportunity to introduce these resources to patients earlier on in their healthcare journey, I personally believe would be very helpful. And I was a little saddened to see in that one graph that, the chaplaincy participation in kind of arranging family conferences or ethical discernment or even attending family conferences wasn't a little bit higher. And I think it needs to be more of an integrative model where chaplaincy, spirituality, and religion need to be truly integrated into the care of those patients who want it, and perhaps not just relegated to advanced stage, end of life, do not resuscitate. And I think that's what we saw in the study, that there is a little bit of a skew, a right skew, and how can we adjust for that and have it more across the entire continuum of care for patients.
That's fascinating that you highlight that. As we read it in Transforming Chaplaincy, that was one thing that stood out to us too, of, oh my goodness, what if we get more involved in these parts of care, and how important is that? So thank you for highlighting that.
Mm-hmm.
So Dr. Palmer and Kelley talked a little bit about how you're doing more with this research, but obviously for one study, you have to choose and select certain variables to look at. You leave out others, or you might not have access to all the variables that you would want to look at. What other pieces of information do you think would have been helpful to examine in this research?
Sure. So I think, some of the things that we'd like to examine is a little bit more granularity around what exactly are patients, looking for, what services do they want. Because, this study looked at what services were utilized by patients, but typically people only utilize things that are available, right? So if it's not available, they can't utilize it. So one of the things is a further exploration of what services do we provide that are being utilized, and perhaps, what is it that we don't know what we don't know. So what are the things that patients may be looking for that we're currently not offering? I think also, we've done some studies, and I know George and others have done some studies looking at where do patients want to kind of interface with this topic. Is it their physicians, their surgeons, or is it their nurse, or is it their social worker, or or, who is it in this group that would be the want to kind of introduce this topic that would be most comfortable, and it may be different for different patients. So that's something else that we've been looking at. And then another topic that we've been examining is just different, maybe not only differences within religious traditions, but also differences in, gender orientation, race, ethnicity, and, finding out maybe that different populations are looking for a different amount of engagement from chaplaincy. And that's something that I think we have to be aware of, the cultural sensitivity around these issues.
Thank you. Well, I could certainly ask you questions all day, but I want to open it up to our webinar participants as well. And so, George, I will hand it over to you to see if any questions are coming in. And again, remind you guys that there is the question box where you can type in your questions to our panelists.
Thanks, Petra, Hansi, Liz, Tim. So grateful to that both that you did this great study and that you have joined us to kind of help us talk about it with you. Just a couple of nuts and bolts questions from people. People are asking, can we send them the article? So just a reminder that the webinar recording and the slides for the webinar will be posted on the Transforming Chaplaincy website, and Andy will send everybody an email about that, and we'll probably have it up in a day or two. The citation for the article was on that early slide that Kelsey presented. So if you're at a university medical center, it'd probably be very easy for you to kind of get the article. If you're at a community medical center, give the citation to your medical librarian, and the medical librarian can help you get access to the article itself. Hansi, there's a couple of people who have been very interested in what you said about your flow sheet and your template, and they've wondered, could they get a copy of that? You want to think about that, and if that's something you're willing to share, let us know, and we can maybe put it in the TC website and let people know about it.
Sure.
There's a few folks that are actually interested in how palliative care intersects with this study. So Liz, my sense is actually that palliative care wasn't a field that you examined, but that presumably some of these patients may have also been seen by your palliative care service. I don't know, Liz, Hansi, do you have a sense for that?
I would think so, because of the DNR information in the, that was reflected in the charting. I mean, that's not 100% the case, of course, that they're correlated, but I would think that would be true, that palliative care may have been a service, along with the cancer service. But I don't know. Liz, do you know any more about that?
I think our data set has the potential to be able to look into something like that, but for the sake of this study, because it was sort of like this broad scoping exploratory study, the way that we used the flow sheets, because every time chaplaincy sees a patient, they fill out one of these flow sheets. So some folks that had a PC visit had one flow sheet, some had 70, 80 flow sheets. So we kind of, for each individual patient, gave ourselves like a summary variable that we called like, did they ever? So like, did they ever receive this intervention from pastoral care, whether that be the one time in the one flow sheet or across some point across the 70 flow sheets. So because those encounters are different and were different for each individual case or patient in the data set, it's likely that we couldn't, within the data set that was created for the current study, determine palliative care's involvement. However, if we wanted to in the future look at like the index visit or the last visit, or wanted to be more specific on the actual encounter, we do have data that shows like the department that placed the orders and the encounter, or the location of the patient. That would probably help us whittle down some involvement of palliative care. That's an interesting question.
Yeah, George, we published an article in the American Journal of Hospital Palliative Care, and we use the same data set, a subset of patients, roughly about 3,500 patients, and not surprisingly, we showed that compared with no religious preference, patients who identified as religious had a higher odds of having a DNR and also a higher odds of having a power of attorney or advance directive. But you bring up an interesting point, or the participant does in their question. In that study, we didn't look at those outcomes relative to utilization of pastoral care, but that would be something that we could easily do.
That would be fascinating, wouldn't it? Yeah. Nancy, just staying on the palliative care theme, somebody wants to know, are chaplains embedded in your palliative care team? And, if one of these cancer patients is also being seen by palliative care, which chaplain is going to take the lead? Do you have a way you sort that out, or does it just happen on a case-by-case basis?
Well, we don't have a dedicated palliative care chaplain. The palliative care service does not operate quite that way, and there's just so many palliative care patients all through the Wexner Medical Center for a variety of diseases that it would not really be very efficient to have just one chaplain. So what happens is that any chaplain who has a palliative care patient in their assigned clinical area is expected to be connected to the palliative care group that covers that service. So there's at least maybe a couple of palliative care groups that cover cancer patients, maybe more than that. But for example, our chaplains in the James Cancer Hospital round now virtually with the palliative care teams that cover those patients. And so they are very connected to the palliative care service, but it's not by one dedicated or two dedicated chaplains. We're just too big for that.
Yeah, thanks. Do any of you want to say, Dr. Pollack talked about this a little bit, about kind of, the data suggests that chaplains weren't too involved in the family meetings yet. Do you want to say any more about that? Ways in which there can be kind of identification of, let me just say, we've actually seen that in 2 other studies, actually, a study from ICU patients that Dirk Labuschagne here at Rush published based on ICUs, 4 different ICUs. And we see the same actually from Duke, is that chaplains are pretty involved in end-of-life care for the ICU patients at Duke, but they're not necessarily so involved in the decision-making process. Any thoughts about ways in which we might get at that? We know that religion and spirituality is often an important factor as families are weighing family surrogates, particularly when patients can't make decisions for themselves. Ways in which we can help chaplains be supportive for those families and be more involved in those family meetings. Hancy, Dr. Pollack, Liz, anybody?
Well, I'll just say that our chaplains across the board, throughout the Wexner Medical Center enterprise, are involved in family meetings. But I think I would just say my hunch is that where we have chaplains that are, I would guess that most of the time it is toward the end of life, or where there's decisions to be made around the end of life. That's probably the most common. It's not the only place, maybe, so the data would even reflect that. The other thing I guess I'm hoping is that, people who are chaplains who are involved in these family meetings are charting them, because if they're going and they're not charting, of course, as they say, if you didn't chart it, it didn't happen. So, but assuming that, that is the issue, then it kind of raises to me the issue of, on the inpatient areas, particularly, are the providers inviting the chaplain into that? Does the chaplain have the relationship built with the family, or the patient, that the family and the patient would be the ones to invite them. Sort of just some of the nuts and bolts of the connections on the team. So I think, again, there's some things to explore about that.
Yeah, I'd follow up on that. I mean, as a clinician, I mean, most of my family meetings in the ICU is usually someone's not doing well. There's a disagreement about perhaps next steps of care. And I think, many providers, clinicians default to ethics, right? That we get the ethics people involved. Frequently, even myself, and I'm inclined, we often as providers say, should we also invite chaplaincy, right? I think providers, many don't think along those lines. And so if it's not patient initiated, I think fewer clinicians, providers are likely to bring that up. I think they're much more comfortable saying like, hey, let's get an ethics consult. Let's make sure ethics is there. I find, at least in surgery, not many surgeons grace it's like, let's make sure chaplaincy's at the family meeting. So if the patient's not saying it and the nurse is not saying it, so how can we educate providers about the importance of, chaplaincy also being at the table, or at least ask the patient and the family, would it be important for you for someone from our chaplaincy group to also be at the family meeting, to give them an invitation that this is okay and we can help facilitate this. I think we can do better as clinicians facilitating those conversations.
Yeah, thanks, Dr. Pollack. I think actually as chaplains, we probably can do better too. There's a nice paper from our colleagues at Indiana University Health, IU Health, about kind of a chaplain-initiated intervention with ICU patients. Any new ICU patient, the chaplain calls the family within the first 24 hours, 48 hours to kind of get acquainted with the family, let the family know that the spiritual care is available for them if they want it, and that they can provide spiritual support and emotional support, and they can provide help with decision making. So we wonder whether or not that kind of more intentional reaching out early in the ICU admission, in particular for patients and families, will actually mean that chaplains are more integrated, helping those families make difficult decisions, come to terms with difficult prognosis. The other resource I should also mention actually is that there's a great book of case studies about chaplains as partners in medical decision making that came out during the pandemic in April, edited by Jeannie Werpsa at Northwestern Medical Center here in Chicago, and Karen Pugliese at Central DuPage Hospital. So I think the book is called Chaplains as Partners in Medical Decision Making. It has 9 case studies that illustrate the ways in which chaplains are involved in helping patients and families make difficult decisions. I think it's been an underemphasized part of our practice and of our training. We've been focused on care at the end of life in lots of ways, but I think we as chaplains maybe can also do a better job of reaching out to those patients and families, letting them know we're available, providing support for them in a difficult time. Petra, I promised that when we were getting near the top of the hour, I would turn this back to you, and I think it's that time, isn't it? We've had a number of other good questions, friends. Sorry we can't get to all of them, but Petra, I'm going to turn it back to you to wrap it up.
Yeah, it's sad that it's near the top of the hour. This has been great discussion. And again, thank you to the team. We wanted to finish by highlighting other publications done by the OSU team. We always love to see collaboration, and the impressive work that is coming out of OSU is really mind-boggling. And so here are another few resources for you to look at, to read in your own time. We also wanted to draw your attention to a few other upcoming things in transforming chaplaincy. So there are 2 upcoming webinars in January. The first is on psychospiritual development and moral injury, the implications for patient and staff care, and that's January 6th at noon Central Time. There's another on charting spiritual care, the emerging role of chaplaincy records in global health care with Simon Peng Keller. And so that's on January 11th, and we invite you to sign up for those. We want to continue to remind you also of our research literacy courses. So Research Literacy 101, which is a 5-week course, and we have 2 sessions that will be beginning, a winter and a spring session. And then Research Literacy 102, which is a deeper dive. That's a 10-week session. And so we invite you to go to the TC website to sign up for those to get more involved in research. And just want to conclude with a big thank you to the OSU team. This really is groundbreaking work, and we were so glad to learn a little bit more about it today. So thank you, and we look forward to reading more.
Thank you for the invitation. We appreciate it.
Thank you so much.
Thanks, guys. Really appreciate it. And thanks you all for joining us for the webinar.
Yeah, this was great. Thank you all.
Take care.
You too.
Bye-bye.
Bye-bye.
Yeah.